So next we have the 3 days after open colonic surgery, a comfortable patient has developed abdominal distension and free air beneath both the hemidiaphragm on an erect X-ray. So what is the most likely explanation for this air under the diaphragm? Would it be a perforated peptic ulcer, an anastomotic leak, a perforated sigmoid diverticulum, a normal postoperative finding, or a diaphragmatic injury? So the patient is third post-operative day after open colonic surgery and they have air under the diaphragm on both sides. So that is the question's main explanation. Now, what it is? So basically, it's a normal postoperative finding because residual intraoperative air after laparotomy or laparoscopy is expected to stay for several days, and for a open surgery, it is even going to stay for a longer period of time. So, what is the cutoff value? So, the residual free intraperitoneal air is a normal finding up to 5 to 7 days after laparotomy or even longer for a laparoscopic procedure. So that is very high yield to know that for a 5th to 7th day post-operative, if you get a chest X-ray, you are likely to find normally both diaphragms having air. Now, how will you differentiate this normal air under the diaphragm from the pathological air under the diaphragm? So how can you differentiate? So the main thing that will help you differentiate is the clinical status of that patient. So for the normal air under the diaphragm, the patient will be hemodynamically stable, but for the pathological air under diaphragm, the patient will be hemodynamically unstable. That how can you establish that? The patient will have a decrease in the blood pressure, they will have an increase in the heart rate, they will have a decrease in the urine output, and they might present with a decrease in the GCS as well. Now, the patient in our scenario is comfortable. There is no sign of sepsis, peritonism, or hemodynamic instability. So, these are the three things which you have to rule out, that whether the patient is having sepsis, signs of peritonitis, or hemodynamic instability. So, free air from the anastomotic leak or perforation would be associated with peritonism, fever, tachycardia, and even severe sepsis. So, even this patient will be having an increase in the temperature as well. Now, always correlate X-ray findings with the clinical status. So, in this scenario, our major principle that we need to focus is the air under the diaphragm being correlated with the clinical status of the patient. So, free air under the diaphragm after laparotomy is normal for around 5 to 7 days, and laparoscopic carbon dioxide may persist even longer than air in open surgery. Now, always relate clinically. If the patient is stable and comfortable, always go with the observation. Now, how does anastomotic leakage present? So, it would present with fever, peritonitis, and sepsis. And now it will not be represented on the day 3. It can present on any day. Okay, usually anastomotic leakage is likely to develop at the 7th day, but it can happen before that as well. Now, never act on the chest X-ray finding without clinically correlating with the status of the patient. So, this is our air under the diaphragm in a normal scenario.